So one of the other things I like to do is, for those who know me, is kind of look into the future. And today's headlines, Dateline Canada, November 2018. I wish I could say this was a forecast. It's more like a wish. But hopefully this is where we could maybe get to in a couple of years, and then we'll kind of get into the at-issue panel around how do we get there? What are some of the challenges? Are they real? Are they myths? What can we do, like Michael is doing, to further deploy and scale and really attract some of those innovative solutions into the Canadian marketplace so that we could take advantage of those to sustain our healthcare system. So number one, everyone is connected. Just imagine every clinician and every consumer connected to each other. Clinicians and consumers are also connected to your health information. We're totally avoiding unnecessary tests, and no one is lost in the transition of care because everyone is connected. Apps are everywhere. 2 years from now, let's say we've got 1,000 curated and certified apps in the App Store that we as consumers can choose from, download, and utilize on our device of choice. We have another 200 apps in an apps formulary that our clinicians can prescribe for us, so we could use those in the context of our care provisioning through our clinicians. And then finally, the jurisdictions have deployed 100 apps for us as well, because some of those are against, let's say, provincial services and assets, and they need to bring those to us as consumers and even as clinicians in that context as well. And then finally, we're seeing bends in the cost curve. We're seeing costs go down. We're seeing patient satisfaction going way up, and of course, an improvement in the outcomes in healthcare delivery. So those are kind of the things we all aspire to, and we're looking for ways as to how we could get there. So I guess, gentlemen, we'll bring it back from the future into the present. So to that end, our at-issue panel today is really around how do we leverage the innovations that are being developed both in Canada and worldwide and get them deployed and scaled broadly in the Canadian context and aligned with the Canadian healthcare system. Michael talked a lot about numbers. I want to just throw out some more numbers for you. I've been working on some material for our board meeting in a couple of weeks, and through some of the analysis I've done, I've studied the investment in startups through some VC reports. And if you're not familiar with this, the number one industry sector for VC investment is digital health. And it exceeds all other industries like fintech and telecom and other areas. So it's a big, big play for a lot of investors. And I've been using the Startup Health VC reports for my insights. And over the last 21 months, worldwide, there's been $12 billion US of investment in digital health startups in various categories, from analytics to consumer health to benefits to devices. In fact, the 50-plus market is getting the biggest share of investment. Half the deals, 2/3 of the dollars are targeted at the 50-plus market in B2B, B2C, and B2B2C, which kind of Michael is in that space where he's providing a service to a business, and that business is then providing a service to the consumers. So there's a lot of activity in that space that we haven't fully leveraged. Another fact is what I refer to as the legacy companies are putting a lot of money as well into R&D. Epic puts 50% of their operating revenue into R&D. It's a huge investment that we need to take advantage of here in Canada. And their competitors are equally putting in big dollars. Allscripts at 34%, Cerner's at 19%, just to give you a couple reference points. So there's a lot of investment by what I call these legacy companies through their R&D. So it's not just $12 billion of investment over the last 21 months. It's probably at least 50%, maybe 100% more than that. So there's certainly no shortage of investment. There's no shortage of creativity being developed by the startups and or legacy companies. And really the issue for us that we want to discuss with the panel today is what are those barriers for further deployment and scale? Are they truly barriers or issues, or are they just myths? And we just kind of need to dispel those myths. And we've got three very interesting perspectives. Hopefully you saw the video and kind of understand their backgrounds. So they're selected to be with us today because they can bring that different perspective. So I have a few questions I'll start off with to engage the panel, and I would encourage you, if you have questions and if we have time, to think about some thought-provoking questions and issues as well. I know there's some entrepreneurs in the room as well, some jurisdictional folks, some clinicians, and maybe you have some perspectives too as to what the issues or barriers are. So why don't we get started? We got Mark on the far left, Ying in the middle, and Josh on the right. Let's start with the money side, since I put so much emphasis on the money side. Is that really an issue for the development of solutions? And on the public sector side as well, do you see it as an issue there on the public sector side? Mark, you're one of the money guys up here. Maybe you could start with your perspective.
Sure, happy to add a few thoughts on that. Man, we've had quite a preamble here. We've had a very, very successful entrepreneur just explain how he did it and how he turned down millions and millions of dollars and all that kind of stuff. It sounds so easy. It sounds so. It might sound so easy, but let me put it this way: money is still an issue. Money is definitely an issue. It's not easy money. It's becoming more and more over the last few years a concept of clever capital. So the venture funds, the pools of capital, they've caught up over the last few years from not understanding healthcare, not understanding the digital health and the technology side of the delivery of healthcare, to suddenly catching up and maybe at a moment in time, maybe even this year, thinking they know it all. Right? And so there's been a little bit of movement. There's a lot of cash moving and that sort of stuff. A lot of noise as well. But I would say it's still an issue. And why is it still an issue? Because capital is attracted to a few things. Okay, capital flows are attracted to tangible and proven business models. We have some proven business models in the delivery of healthcare tech now. We have great examples all over North America, all over the world. And we're becoming more and more aware of them. However, capital is also attracted to, I think, three essential things. One is teams, so the management teams, the masters of that operation, like Michael, who was here just a few minutes ago. It's plus product or technology or a service method that is beyond reproach, really, really strong. Plus, evidence of traction in the market, which means market validation, which means, again, now it's getting to the cash flows. Can a company earn revenues against that? Or can they attract yet another government to continue to procure from a technology business into the future? Yeah, so there's still an issue there. Yeah. Josh, Ying?
Yeah, you're on the other side of the table from the money guys.
Yeah, I'll kind of talk about it from my company SeamlessMD. We're a patient engagement digital health company, and we've raised about $2.2 million from private capital, so venture capitalists, angel investors, and the sort. And when I think about digital health companies, I think you can put them on a spectrum. So, at one end you have maybe the major life science pharmaceutical companies. You might need 10 or 15 years worth of capital just to get a product to market and get validation there. On the other end, you can have, direct-to-consumer software companies that can, with the cost of deploying software significantly lower than it was, years ago. You can get a product to consumer tomorrow. As a software company, we sell software to hospitals, so we're business to business. We're kind of in the middle where, it could take, a couple of years of time to develop evidence and adoption in the healthcare market among hospitals and health systems. So, we might need a couple of years of capital to get to those proof points. And one of the challenges that we found in the healthcare landscape is that if it's your first time company, it might take you a year to get your first deployment or your first contract signed with an institution, given all the bureaucracy and barriers in the way. And so I've seen a number of entrepreneurs find it very difficult to last to a year before you even get your product to a patient or a caregiver. And if you don't have the capital to last even that long to get your first deployment, how are you going to get to 3 years? So, I think we need support from the community to know either how do we shrink that time to deployment, or how do we get better support from capital to understand that longer term vision that digital health companies actually need to get evidence in the market.
Anything to add, Ying?
Yeah, I mean, I'd like to say it wasn't a problem. That would be a great thing to say. But the reality is cash is still king.
Yeah.
And, I've worked with a lot of companies, digital health companies at Mars, and lots of them fail. I mean, the ratio of 9 out of every 10 startups fail. I think 8, maybe it's 8. It's still a reality. I mean, I think when I think about my first startup, we raised $15 million. That's what it took to get a digital company to market. 5 years ago, it was down to 3 to 5 million, something like that. And now, the IT companies, the digital companies can get a product to market in, 50,000, 100,000. You can get something into market. But the reality in the health space is that there's a lot of barriers. There's regulatory, there's the validation, there's a lot of issues in that the surviving to a year to get to those major milestones that show traction takes money. And
So let's talk about the other side of the money equation, right? There's the capital to develop, but then there's the revenue side, right? Once you sell, and one of the challenges there is getting that opportunity to sell, partly in a publicly funded system and a public sector delivered system. It often involves procurement. So how do we innovate that so that if you're the first of, they may not even know that kind of solution exists. How do you kind of get into that procurement cycle and even innovate procurement so you have an opportunity to sell and deliver in some creative ways? Any thoughts there? Maybe we could start with you, Ying, again.
Yeah. I mean, I'd love to talk about that. I think everyone would agree that there's problems with procurement. I don't know if anyone would say it's a disaster, but there's certainly issues throughout the whole procurement process. I think at the very high level, the whole directives, the guidelines, I think we would probably all agree they're probably okay. I mean, the whole idea of those is that it's supposed to drive, transparency, fairness. I think we're all okay with that. But it's all the other stuff that we in the system have overlaid on top of that have created all of these costs, these barriers, these bottlenecks. And I think there's all sorts of opportunities to remove those. I mean, so I started my career at IBM, and I remember, we used to always get these RFPs, and which is really common in the healthcare system. And, there was always a question. It's going to cost $1 million to answer that RFP. And let's not even include the costs that it took to create that RFP and the whole process around that. I mean, think about extracting that out of the healthcare system and being able to deploy that somewhere else. That would be an amazing thing. So I think there's interesting models that are being generated in other geographies. I think Europe has generated a lot of different ideas around procurement. I think a couple of them are being piloted here. So I think, at South Lake, they're using this thing called competitive dialogue. Sounds like something my wife and I do on occasion. I'm glad everyone's still awake. That was just a test. But it's the idea that the vendors are creating the requirements. So they're getting together, creating the requirements. So instead of...
So is it outcomes-based? What was asked of the vendors?
So I think both of these things I'm going to talk about is completely outcomes-based.
Okay.
So, I think that's the end result of this.
Yeah.
But so they're not having to go through the whole, let's gather the requirements, put the RFP together, let's hire a consultant, let's go through that whole process.
Yeah.
We're removing that out of the equation, or at least they're trying to. I mean, the pilot that we're doing at Mars is this procurement by co-design, which is this idea that the institutions put out a challenge. So instead of going through that whole requirements process, they put out a challenge out to the community. The vendors bid on trying to create an approach to be the one to create an answer. So both the institution and the vendors co-create a design, a solution to address the problem. Right. So it's funny enough, I did get an email that I just wanted to talk about this afternoon. I thought was interesting. So this pilot that we're doing at Mars, this procurement by co-design. So the first call went out, 19 providers in Ontario submitted 28 challenges. There were 161 responses from the different vendors. And then that got narrowed down. So there was a process of matchmaking, got narrowed down. And now there's 25 project teams, that's 14 providers, and 19 vendors working on 20 challenges. So, and the whole idea around that is it's outcomes-based. They're trying to create a solution to a problem that they know they have. That solution doesn't necessarily exist right now. It's not something that they're going to try to pull off the shelf.
Yeah. Yeah.
Specifically to address an outcome. Yeah.
So Josh, what about you in the hospital sector? Did you have to go through procurement to get your first of deployment in a?
Yeah, I mean, so we started off locally in Canada, done some great work here in Toronto, Montreal, now Ottawa, now Hamilton, and now we're doing work in the U.S. as well, a number of states. So we've had an interesting look at how procurement works in several provinces, but also in the U.S. as well. I would say that in Ontario, because of the guidelines, we can be creative and find ways to land maybe our first initiative with an organization. I think given the structured procurement, I think we're still facing barriers around, well, how do you grow with an organization in a way that doesn't complicate that relationship, or you could start with an organization, but the moment you try to do something being hospital-wide, maybe you have to go to a much larger procurement process, and in some ways it becomes unattractive sometimes to put in the effort and work it takes to do something that big when even the organization wants to, it might not happen. And so I don't have a good answer for that. I do know there's some good work happening at the ministry level to solve that problem, and I think some things are gonna happen with that. But I would say right now, if you're an early stage company, it's possible to get deployments here, but it's still very hard to sustain revenue here going to the healthcare system. And because of that, even though we're Canadian grown, we have to look to the U.S. to sustain our business. Mm-hmm. I have a full-time team of, it's going to be 11 very soon, and I have to keep the lights on and find ways to do that. So I wish I had the answers. I'm still waiting on those two myself.
Yeah. Mark, do you have something?
Yeah, I mean, there are some good examples. There's lots of things happening, and here's why. In technology and in healthcare especially, there's a high velocity of change, right? So the procurement process of, oh gosh, you're gonna have to do all these responses and everything, that's almost a non-issue. You just drop it, you move on, and you try another creative way to get money in or to get a customer, right? But Ontario's trying to help innovative healthcare companies and partner with clinicians and partner with the government, let's say at the source. And they're doing it through something called the Healthcare Tech Fund. Through our Office of the Chief Health Innovation Strategist, they've moved some money, let's call it pennies, to another organization that is now vetting, right, a whole bunch of proposals, right, for innovative companies to partner with the public sector in some shape or form. That's one example. There are others in other provinces for sure. Nova Scotia tried this through their innovation agenda maneuvers a few years ago. Here's another one. Here's a bit of a challenge. I'm an investor. We run an investment fund. Always curious why a company that's proposing to provide a service or a technology to a big customer like a province, why they wouldn't say that they would allocate in that delivery of service, they will allocate funds or some sort of effort on trying to bring in other vendors on their own, right? So they're already leveraging, this is where the buy is, on our side as a source, and we're going to buy some more. Here's how we're going to help the government de-risk, for example, a purchase. Let's break through some of those original guidelines.
Yeah.
Do you remember the guidelines that came in? There was the big scandals of people claiming, a muffin and a coffee,
Yeah.
And putting it through an expense claim, and we said we're going to
Yeah.
stop that. Well, I was part of an organization called the OA-CCAC, the Community Care Access Centers, when those guidelines came in, and we thought we couldn't buy anything forevermore.
Yeah.
Like we couldn't do anything. So we had the minister come in and their team to explain to us what the guidelines meant, and they were guidelines, right? So if you could move through that, you could start to open up the procurement process.
Let's pick up on that prove word, kind of the return on investment. If I were the clinician or the buyer, right? And especially clinicians love evidence, right? They love to see the evidence that maybe this new technology, whether it's software or med tech, doesn't really matter. Whether even if it's a new pill is safe and is producing the outcomes that one expects, and it's at the right cost point. I remember meeting with a vendor about 18 months ago, and I'll leave them unnamed, but they were commenting on the fact that they had evidence to justify their software solution. And so I said to him, well, then why don't you sell your product to them based on outcomes instead of based on seat licenses or some other metric?
Right.
How do where some of these innovations are somewhat new and novel, maybe to some degree unproven clinically, would you take that kind of risk? Would you sell to a hospital and share the value creation? Putting you on the spot.
Yeah, no, it's a model that we think about, but here's what I'll say. We talked about procurement just now, but my opinion is that procurement is actually not the big barrier for us, as much as it seems that way on the surface. We could fix procurement for vendors and for organizations in Ontario, but that, in my opinion, would not actually markedly increase our adoption of our innovation. I've been invited to speak at meetings and committees for federally and provincially for how do we get more healthcare innovation, and I always give the same message, which is that it's not about getting more healthcare innovation for the sake of innovation. If you fix the incentive models, if you actually tie your reimbursement or your funding to outcomes, to value-based care results, you will pull the right innovation out of the healthcare system, whatever that might be. Better outcomes, lower costs, great patient satisfaction. So, we don't do that here, right? Still primarily by far, we fund based on fee for service. Until we fix that model, it doesn't matter if we fix procurement, even if someone wants to engage in outcomes-based or risk-based funding, they're not going to do it here because there's no policy saying you're going to be paid that way. I'll contrast that with our organizations and health systems that we work with in the US, where the Affordable Care Act, Obamacare, and other policies that have been very progressive in the last 6 years have dramatically shifted reimbursement to both health systems, to physicians, to facilities, from fee-for-service to value-based care. So, in 2015, the U.S. Department for Health and Human Services says, we're going to set a goal where in 2018, half of our payments in Medicare are going to be through non-fee-for-service. They're going to be through alternative payment models, like a bundled payment. And 90% of our payments in 3 years are going to be tied to value or quality in some way, such as readmission rates for organizations. It's that change in the environment that's created a significant amount of demand for innovation in the U.S. market, and that's why we're getting demand even though we don't even live there. And so unless we fix the incentive models here, it doesn't matter if we're procurement. It doesn't matter if people want to engage in risk-sharing models. No one's going to adopt the solution unless there's a real urgency from a reimbursement point of view.
Right.
You talked about ROI a little bit there. And so, in everybody's experience, you're trying to sell, you're trying to encourage somebody to take up your service or whatever in business. And it is a responsibility of the vendor to explain the ROI, but explain the ROI in the context of, or in the frame of reference that the purchaser may have, right? And so if we're trying to sell into the Ontario government, or the Ministry of Health or some of the agencies of this healthcare sectors in Canada, we have to really be working on spending time on their strategy. So the healthcare strategy we start to hear about today, or I heard about today from Dr. Bell, spoke about the consumer side of healthcare. And I thought, okay, great. So that is a shift. It's not always the same. It hasn't been the same. But now he's begging us to understand that and then sell into that and calculate all our returns on investment and our value as technology vendors against that model, which is more of a consumer model, right? So we should do that. And vendors should take some of that risk and should come up with creative ideas. If they have a sense of urgency, they want the sale, they should create some ideas on how to share that risk through transactions.
Right.
So use of the technology. Why not for a period of time? As long as you have commitment from the government or the purchaser that they will come in and partner for the long term, right? They won't just leave the companies hanging. Then why not? We did that in software companies in the mid-90s when we were selling into the financial services industry. Again, the investment banking industry. It was all based on how many trades you could see your software managing, like in mutual fund trades or bonds or whatever. And the software vendors said, you know what, for sure, you don't want to pay a license fee for that software, for the right to use that software? Fine, you'll pay us on how many trades you have during our RRSP season. And the software vendors made a lot of money because the software was good and it met the strategy, right? So we could start to do that in healthcare too, but...
Yeah, I'm sensing the ministries as payers are kind of being more open to innovation and to new approaches, more so than I have kind of noticed in the past.
Yeah.
But that kind of gets back to one of the things we often hear when we compare Canada to the US. The US tends to be more of a risk-taking culture, more entrepreneurial. Canada tends to be a little risk-averse, especially in healthcare, less entrepreneurial. Any thoughts on that, especially for those of you who've worked in both north and south of the border?
I think the risk adverse is what drives our procurement problems, as one example. I mean, I think because people don't want to make the news, they want to be on the front page, having done, they're trying to cover their butts. The RFP process is actually so onerous because of that. But just going to jump back to a couple of other points. Sorry,
Yeah,
Dennis,
please.
I know we only have so much time, but I do think if we were going to use those headlines, I think that one of the headlines is going to be that we've moved to outcomes-based, value-based. Yeah. I think that's inevitable. I think we're moving that way now. The bundle payments, I think we are moving that way. And I think maybe we're behind. We probably are behind because we're risk-averse, but I think we're going to get there. I think one of the examples about, other methodologies is the social impact bond. I mean, that was, that is putting the risk out there, so I think there's other ways that we're trying to address, where that risk lies in the system and trying to create some sort of return for it.
Do you want to tell folks about the one that was just announced here in Ontario?
I don't have enough details.
Okay. Well, it was around hypertension.
Yeah. Well, I thought there were two announced, but...
Yeah, and I'm not going to remember all the details either, but it was largely some investors, some unnamed, that put the money into this program to reduce hypertension and the resulting morbidities associated with that to get a nice return if they get the outcomes. So, there's a social value to that kind of investment that should have an appropriate financial return to those who are taking the financial risk. Yeah. Are you familiar with it? Maybe you're an investor. I don't know.
No, I'm not an investor in that one, and I did find it a little confusing at first.
Yeah.
I'm going to get return only if you guys are really, really successful, and what happens
if the outcomes are met, then you get your return. So you're betting on the fact that I'm right about my outcomes.
Yeah, and as an investor, I would also want a part to play in that success, like somehow to help influence that success, right? In some shape or form, rather than just sitting back
and some caveats around it, around care.
And that's encouraging.
Yeah,
sure.
Encouraging. But there are some innovative approaches to how we're looking at some of these outcomes-based results and even digital health investments in that context as well, which is really nice to see, as you pointed out.
You know what happens in the U.S., though, and in Canada, too? I mean, some of the successful technology businesses and the vendors, they will kind of create a differentiated portfolio. They'll have some customer base in some region that is very basic and concrete, and there's a bit of cash flowing from that, and they'll take, zingers, wingers, whatever. They'll be much more risky in some other customer base at the same time. And so it's, again, one of those, it can't be just the startup for the very first customer. It has to be a strategy if you've got varied customers across varied regions, maybe even US versus Canada. And again, we're leveraging, putting technology into play based on somebody at the company or somebody at the vendors figured out they can take from this pot and put over to here, and then hopefully succeed across the bigger picture, right? So that happens a lot as well. QHR was one of those companies where I was on the board of, as you might remember.
Yeah.
And it had varied businesses, and it tried to pull cash flow from this business for a while to build out the EMR core assets that became something of scale. But there was a point in time where we had to move the money in the markets so that we could support that innovation, that new innovation called EMR, let's call it. Yeah.
But just back to your original question. Sorry, didn't mean to digress
I don't even
so
remember
much.
what it
Well,
was.
it's about the validation, the clinical validation.
Sure.
And so, I think digital health actually gives us that opportunity to actually get to that spot.
Okay.
I think if it's medical device, if it's pharma, you're committed. It's a 5-10-year path. It's $50 million. Digital health allows you to kind of pivot to try to get to those get to those measures, which is a huge opportunity, really.
Right.
If you think about it.
So let's kind of pivot a little bit. I've been in IT for 30-some years. And we've always said, if you have a bad process and you automate it with IT, you still have a bad process. It just runs faster. What comes first in this world of digital health? In fact, I'd rather even think of it as healthcare that's digitally enabled. Is it the kind of the process and even incentive reengineering that has to come first, or is it stimulated by these new solutions? It's a bit of a chicken and egg problem. How do we kind of navigate through that challenge of kind of what comes first, and if I really do need to re-engineer the process or change the incentives and the alignment of incentives among the clinicians and the payers and even the consumer having some skin in the game and some accountability for their own health and their own outcomes, like take the pill, damn it, every day kind of approach. How do we kind of manage that in this context? Any thoughts?
Yeah, so I think you're absolutely right. I think incentives matter. I think if you want to get...
And let me just, if your questions, maybe you could queue up at the mic here and we'll take a few questions.
If you want to get widespread adoption of best practice, and it doesn't matter if it's a technological innovation or a new model of care or a new policy or social innovation, you have to fix the incentive models because you'll get what you paid for essentially in the healthcare system. But going back to your question before about are Canadians as entrepreneurial as our counterparts in the U.S., and I think in my experience we absolutely are. We wouldn't be able to be doing work in the hospitals that we are if there weren't entrepreneurial clinicians, administrators, frontline workers who didn't want to do this even though there was no incentive. They're bringing our solution in because they think it's the right thing for their patients, it's the right thing from a care point of view. And one of the organizations we work with in McGill University Health Center, we work with them to support their enhanced recovery after surgery program. And I'm not going to go into details about that, but basically it's an evidence-based protocol that's been proven over 20 years to reduce length of stay by a third or a half. And McGill was the first organization in North America to do this model 10 years ago. 6 years ago, it started popping up in pockets in the States. And when we meet with organizations in the US, all of them will say, oh my gosh, you work with McGill, they're the best in the world at this. And so, whether technology or care models, we are entrepreneurs in Canada, and we've brought a lot to the world. I just think that, you're still going to get the McGills and the other, quality-focused organizations to do these entrepreneurial things and do best practice and adopt innovations. But if you want everyone to do it, you're going to have to switch the incentive models so that everyone's aligned in doing it. you're still going to have the McGills, but if you want everyone to do it, you gotta
Yeah.
fix those incentives.
Yeah. Ying, any thoughts?
Well, just in terms of your question, I don't know if clearly I'm biased, but I think we all live in a system that we're used to, and it's hard to think outside that system. So we have a healthcare system, we've lived in the healthcare system, so we're kind of stuck in that. So I actually think the digital health is what's going to drive it. So people, have a problem, they're entrepreneurial, they have access, they build something, it plugs into that will drive change inside the healthcare system. I think that's the way it unfolds until we get the next generation of entrepreneurs, innovators, healthcare people that think in both those systems, and they will be able to generate evolution.
Mm-hmm.
That's kind of.
Clinicians may disagree with you,
yes.
but that's okay.
All right.
Mark?
I hear the question, and I'm not sure I can agree totally with everybody here. I hear it as, I'm not so sure the technology is driving the system. I view it as the technology is enabling the satisfaction of a market need. And the market need is being driven by a whole bunch of people trying to do really, really good things. Maybe respect a new incentive model and follow along because they know that's the best thing to do. Strive for better outcomes, and the technology should help them get there, right? And we should figure out ways to bring it in the back office way, forward, and be a supportive role. But
yeah, I mean, I tend to be where you are. I view it as an enabler, but I think, having worked on many V1 products in my lifetime, we also have to inspire. It's kind of the Steve Jobs approach, where you didn't know you needed one of those, right? We didn't know we needed iTunes and digital music and a player to enjoy music and videos and TV shows and so on and so forth. So to some degree, those of us who are coming up with these creative solutions kind of need to inspire, whether it's the payer, the clinicians, the health system, the health delivery orgs, or consumers, as to what is the art of the possible. We kind of have to take on that role too. Any questions, please?
So I have one question. It's about risk, capital, and the opportunity of digital health. You mentioned about the amount of funds that have gone into digital health companies over the past number of years from VCs. And what has come out recently is that a lot of those VCs have not seen the returns that they were expecting. How do you see this impacting the opportunity of digital health? Because it has a huge, enormous impact on process improvement. And how does, the inability for the current companies that have received capital to show proper returns and the impact that would reflect upon risk of those types of investments moving forward?
So I have kind of two comments on that. So I think there is a belief that where much of the money has gone before, that's done, and VCs can't get the multiple that they used to get, and so they're looking for other areas, and I think health is one of those areas, and I think digital health is a key focus. So I don't know if you've heard this expression, software is eating the world. I think Andreessen Horowitz is investing in digital health startups because they think software will eat healthcare. That is their point of view. They came to Mars, they actually, for Venture North, they came back and looked at 4 different healthcare companies, 7 companies overall. So there's a huge interest in that space. So I'm not sure I agree. So my second point is I'm not sure what their timeline is in terms of expected return. So, I mean, I don't know if you were at Resi last year, and one of the panels, one of the investors said, a year ago, he didn't know how to spell digital health. And at the panel, he said the only thing he's seeing is digital health. So I think the digital health investments are still pretty new, and I would be surprised if they think they're going to get a return right now.
Anyone else? I see one more question over here.
But it is hard to raise money, I know.
So with the move towards outcomes and the whole kind of patient-first approach to it, I'm just wondering what your thoughts are in terms of the patient experience or the individuals who are actually it seemed to me that the government wants to measure what those outcomes are like. Do you see that experience as being the source of inspiration for disruption in this industry? We seem to talk a lot about disruptive technologies, and I'm just wondering if the patient experience itself and learning about that can be the catalyst for that change or disruption in this industry.
Yeah, absolutely. And I'll touch on a couple of points related to that. I mean, one is I think healthcare as a whole has started to realize that outcomes beyond just clinical outcomes really matter, right? We have the clinical outcomes around infection rates and readmission rates and whatnot, but clearly we've realized that patient-centered outcomes matter, right? When a patient's having a hip replacement, the surgeon might care about the infection rate, but the patient cares about, will I be able to go to my daughter's wedding? What's my pain going to be? Will my hip be able to move the way it used to in a couple of months? So, now we're starting to see that it's important to collect those outcomes, and we've had organizations ask us to collect those outcomes as part of the patient journey through surgery, for example. The second thing I'll say is that, we're a company where we provide our solution to organizations like hospitals and health systems, but our users are both providers and patients. And if patients don't find value in our experience, they're not going to use our solution. They're not going to submit their patient-centered outcomes data, which means providers won't have data to learn from and deliver better care. So at the end of the day, we have this kind of two-sided market in our solution where you need the patients to be engaged and satisfied in order for the providers to be able to act on that data. And so, absolutely, if you're designing a solution and you're not engaging the patient and you're not creating value from them, at least in our case, we're in trouble. And so, we spend a lot of time, patient focus groups, surveys, end of program feedback conversations, continuous improvements based on that feedback. It's critically important. And as more and more things are being brought to the consumer, as more consumers have more control over their health or how they pay for health, you better darn be, engaged in that and understanding the experience and providing value. No question about it.
I would say that, I don't know if you've ever heard anyone from Mars pitch the future of health, but that's fundamental in Mars's view that the patient is at the center of health and is what's driving health changes or changes in the healthcare system. So the patient is involved completely in their health. There's a person that talks from Singularity University, and she says, that she had to fire her whole healthcare team and become the CEO of her own health so that she could live a healthy life. So I think that, we talk about the future of health being driven by the patient-enabled solutions. We talk about, running out of money, and we talk about the technologies that enable all those changes to happen, and the patient definitely is driving it.
Well, I'm getting a blinking red light up here, which means we're slightly over time, so please join me in thanking our esteemed panel for this interesting session.